here now, and I'm going to pull up my screen here. Can you guys see my screen yet?
I do not.
Okay, let me. How about now?
Yes,
Beautiful.
got it.
Okay, good. So the purpose of this little exercise here, in the military, when you're judged on certain tasks, you get what's called a go or a no go. And so the plan this evening is to have a little bit of fun. What I'm going to do is I'm going to show you a waveform. It could be a sensory nerve waveform. It could be a motor. It could be an H reflex. And I want you guys to look at it. And, so go through the process. Does it look like the correct waveform? Are the cursors in the right position? Do we have a stable baseline, stimulus artifact? Take a look at it and then tell me if you would give a go or a no-go on this. And then let's discuss on what can be done to make it a better waveform. Okay, so here's our first waveform. This is a sensory nerve waveform, and it could be any waveform. It could be a sural, or it could be a median.
Right.
But take a look at this and give me your thoughts on
You know,
this.
my
And
yeah,
go ahead.
I would say that there's a there's pretty sizable stimulus artifact, and it doesn't look like it. It's hard to really see where it returns to baseline. Um, it'd be hard for me to know exactly where the onset is based
Yeah,
on that.
yeah. I mean, there's a huge stimulus artifact. It looks like there could be some 60 cycle stuff kicking in here. We certainly, have a waveform here, we think. How could we make this better? How could we, what are a couple techniques that we could utilize to help, mitigate either this stem artifact or to stabilize this baseline some?
You could turn on the 60 cycle. You could either reduce your intensity if that didn't work to allow you to get a proper stimulus. I would maybe try rotating the anode slightly and see if that helps
Dude,
any.
have you been through this particular presentation before? Because I did make some changes to it, but
Yeah.
that's exactly right. First step to help clear up this mess right here is to turn on your notch filter, okay, which will help to cut out that that 60 cycle interference. This stimulus artifact can be mitigated, one, by reducing your stimulus intensity. Okay. Second thing you could do is try to get a little bit better contact, with the skin, and that might entail, using some gel or something like that. The third thing is if all of that fails, you can rotate your anode, and just by rotating that anode either clockwise or counterclockwise, oftentimes you can find a sweet spot where you'll completely mitigate this and be able to isolate that that particular waveform. Obviously we think this is a waveform, but there's a slight chance that it could be the tail end of this of this stem artifact. So do we have some usable data here? Yeah, we can move our onset from the left side to the right, and be able to get some some usable data, but it's best to try to clean this up here a bit. Looks like Roy Adams has joined us. Bill, do you have a question? Now your hand's not raised there. So, okay, let's go to our next waveform. Looks like Mark has a question here. It says I just got muted. So let's see what we can. I just unmuted everybody, or at least I thought I did.
Okay, I'm good now.
Are you good now?
Yep.
And Roy, how about you?
Yep, I'm up now. Thanks.
Okay. And Bill, I'm gonna unmute you
There
two.
you go.
I have no idea why it's muting you, because I've given you guys control, here on muting and unmuting. So
So I got a question.
yes, sir.
So a lot of times, I mean, you can also reduce the duration of the stimulus, and that might help out as well. Yeah.
That's true. Usually with sensories, we don't want our stimulus duration past 100.
Sure.
Because these are such small nerve fibers that if we start getting 200 or 300 milliseconds stim duration, then that'll really cause some problems. But what Bill's saying is, we want to somehow, some way reduce the amount of stimulation. That is,
As I look at my duration, I look, like if for some strange reason it says 200 on my machine for some strange reason, then I'll go ahead and bring it down to 100.
right.
And that clears things up.
Sure. And you can go into your test setup, and under the sensory nerve tab, you can set your pulse width or stimulus duration at 100 for all your tests. Obviously, for lower extremity motors, oftentimes we'll have to increase that stimulus duration. Okay, next waveform. Here we go. So what we have here is we have a median nerve. We shocked at the wrist, and we got a response. Then we went into the palm, and we didn't get a response.
Right.
Okay. So, again, we're shocking at the wrist. We're recording off a digit 2 or digit 3. Any thoughts on how this is possible?
Well,
I would expect if it was conduction block for it to be the other way around. So I don't know.
That's exactly right. If it
Right.
was conduction block at the wrist, you would get, if it was 100% conduction block at the wrist, you would get nothing with your wrist stem, and you'd get the waveform, with your palm stem. So is this even possible?
I'm gonna guess no.
It's not possible. Okay, this has to be due to a technical error of some sort. When they got into the palm, for whatever reason, they got off the nerve. And oftentimes, as that median nerve enters into the hand, it oftentimes will not follow the directions and the pathway that it says in the textbooks. Oftentimes, I have to stimulate basically in the thenar region, or try to get up under the thenar mass, in order to get that sensory response. Okay, so would we all agree that this particular test, as it stands right now, would be a no-go?
yeah,
Great.
absolutely. I
Yeah.
find myself drifting to thenar too.
Yeah.
Yeah.
Okay, so this is another median.
Okay.
And so take a look at this, and analyze the quality of the waveform, and let me know if this would be a go or a no-go.
Good to me.
Well,
Yeah, I mean, if you're being a little particular, you might change the onset.
well,
Well,
it's a little
onset, for sensories just only tells us about amplitude.
yeah.
Okay.
And if you're absolutely positively nitpicky, you might say, oh, I want to, try to reduce that stimulus artifact. But I've got to tell you, if I generate a waveform like this,
Yeah.
I'm keeping it 100% of the time. I mean, this is beautiful. We have a nice stable baseline. We have a nice triphasic waveform here. So again, would we agree that this would be a go on this particular one? Yeah.
Yeah, looks good.
Yeah, beautiful. Okay, so we're still in with the median nerve here. So we have we have a wrist stem at the top. We got a palm stem. Secondly, so how about these waveforms? How about cursor positions? Quality of baseline. All of that stuff.
Your onsets are off.
Yeah. Yeah, I would probably, for this wrist stem, I'd probably want my onset, right here. What's contributing to this little trough here is probably some of this motor artifact here. And sometimes when doing antidromic stem, you can't not get some motor artifact, especially in a person that's got a small hand.
Right.
There. So again, I think on this top one here, where we have this little bit of nice flat baseline, I would be putting my onset here. How about this palm stem?
I think he's overstemmed.
Well, he probably has overstemmed, got a nice big stem artifact.
Yeah.
How about our cursors?
Yeah, the onset's too low.
Yeah, this, putting the machine put this onset cursor way down the trough to this stem artifact when it probably should be somewhere about right here or, maybe here. Again, as we talked about earlier, we can mitigate this stem artifact by, reducing intensity, by, rotating your anode some. But certainly we would agree, that having an onset cursor down here is not correct, because what's going to happen is somebody looking at this is going to say, man, this is 1, 2, 3, 4, 5. This is 100 microvolt amplitude here, and it's 25 microvolt. I mean, somebody's going to say, "Oh, this person's got a conduction block." Because when we get past the side of compression, we've got an amplitude that's 4 times as large, when we really don't, because our cursor here is not in the right position. Okay,
and if you didn't show that picture, you just saw the numbers, you would think that.
That's right. That's why it's so imperative that we include our waveforms in our reports. Okay, and but either way, guys, you should be picking this up at the time that you do the test. Okay, you've just started that upper extremity exam, and probably the first nerve you do is the median sensory. Before you even think of moving on to the ulnar sensory, you've got to look at your waveforms, make sure that they're acceptable. You got to make sure your cursors are in the right position. And if you move this cursor to about right here, or even put it here, it's going to be the same amplitude as this. Okay. So again, this is why I, reiterate, okay, check your work and fix it before you move on to your next exam, because I know Bill and Roy, I'm sure you've gotten those, that feedback from Dr. McKibben.
Oh yeah.
And he likes to do it in red, and I do it in red also, and save yourself a ton of time, by making sure your data is good, before you send it to them. Okay, so this one here is actually an ulnar waveform. This is also at the wrist. How about this one? I mean, does this look okay? Yeah. Anybody, anybody would anybody reject this?
No.
Again, you can nitpick here. There's a little bit of stem artifact here, but that stem artifact doesn't affect your nice flat baseline. If you draw this baseline out, everything's nice and flat here.
Mhm.
Starting to maybe get just a little bit of some motor here. That's why that trough is, a bit lower here.
Mhm.
But again, I think I would take this waveform 100% of the time. I would
Hey, Mark?
generate this and store it, and I'd save it. Yes, sir.
So, sometimes, like you said, you have a small hand and you're getting some motor responses.
Uh-huh.
Is it better to get a good waveform with motor responses, or get, try to negate the motor responses and
Yeah,
not have as good of a waveform?
that's a fantastic question. One of the techniques I use, especially when I do the ulnar sensory, okay, the one sensory waveform that is most prone to being contaminated by motor artifact is the sensory. It's the ulnar sensory. Why is that? Why is it always the ulnar sensory that looks like a big giant turd?
Well,
What are
the
the
big
only muscles in the hand that are not innervated by the ulnar nerve?
abductor pollicis brevis, opponens,
Flexor
flexor pollicis brevis, and
Half
short
of that.
head,
Uh-huh.
and
And
then
lumbricals,
and that
1 and 2.
lumbricals on the
Yeah.
radial side.
Yeah, everything else is ulnar innervated. So the hand is a giant volume conductor for the ulnar nerve. Okay, so what I tend to do is if I'm getting a lot of motor contamination that's messing up my waveform, I'm going to move my recording electrode out to that first PIP. I'm going to get it away from the hand some. And oftentimes, guys, that will clean up that motor artifact. You're going to get ever so slightly smaller waveform,
Mhm.
but a lot of time it's clean. If your recording electrode is at that IP joint, right where the hand becomes the finger, you're almost always going to get a bunch of motor artifacts. So moving it out to that first IP joint, that
Right.
PIP area,
So,
oftentimes
so
that will clean that up.
and I'm not trying to believe, to hold on to this thing. I get a lot of small hands,
Yes,
and it's rough to get those
it is.
feet
It is.
further apart. So, is it a faux pas? If you can identify the ulnar sensory,
Uh-huh.
and then you have the artifact. I mean, is that a bad thing, or
No. And Bill, hold on to that thought, because I think I've got an example of that coming up. Okay.
Okay, great.
Yeah. And I think it's a couple or 3 slides down. How about this one? Okay, this is a radial sensory.
Yeah.
It's the onset incorrectly put.
Yeah. It's incorrectly put,
Yeah.
but putting it here
Yeah.
might not give us a true amplitude, because we've got this big stem artifact
Big
coming
time.
down, and probably the correct amplitude would be somewhere in here. So rather than putting that here or there, again, we can drop our stem intensity down just a hair, or we can rotate that anode, and that'll fix that. But certainly, I think having that onset cursor here is not ideal.
Does getting something like that ever have to do with too much gel, by chance?
It certainly can, because what'll happen is if you use too much gel, the gel from both of the probes will eventually touch one another, and we call that a gel bridge. And that will, every time you shock, you'll get a humongous, stimulus artifact. So yes, you can use too little gel, and you can also use too much gel. And especially if you're having to move your probes around to try to find the nerve, and you're smearing that gel everywhere, eventually you're going to end up with that gel bridge. And as soon as that happens, your whole baseline will go to hell. You'll have a huge stem artifact. And at that point, basically you just clean it up and start over again. Okay. So again, this is yet another example of where I think if we can mitigate some of the stimulus artifact, get us a good baseline. Again, that baseline, I think, guys, is going to be right in this area here.
Real quick, Mark.
Yes.
Sometimes if you straddle the radius when you're doing the radial sensory with your probe, that if you just you put the you straddle the radius. You know what I'm talking about? Does that makes it clear up a heck of a lot?
That will clear it up, because basically you're changing the position of that anode in relation to the position of the cathode. So you can straddle, or while keeping your cathode on the nerve, just rotate your anode back and forth. So yeah, either of those are very good techniques. Okay, so this is a median here. We have a wrist stem and a palm stem here. How about these? Would we take these?
Sure.
So. Yeah.
No.
I might do the onset on the palm just a little bit, but
Yeah. Again, when we're talking 20 microvolts per division, moving that from there to there is really not gonna change that much.
Yeah.
We've got a good flat area of baseline here. We got a little flat area here. This peak, if you really want to nitpick, probably one click more, towards the right here. But again, guys, I would take this 100% of the time. I would not, I would not turn this away. I wouldn't spend one more second trying to get a better, a better waveform here.
Gotcha.
Okay, so here, this is a peroneal nerve. This is a motor. So we shocked at the ankle, we shocked at the fib head, then we shocked in the popliteal.
The overstimulated popliteal region, yes.
Yeah. So, guys, what type of waveform is this? What nerve?
Jacked up.
Tibia and
That's a tibial. But hold it. Explain something to me. We're recording off the EDB, correct?
Yeah.
EDB is not a tibial innervated muscle. How in the heck are we getting a tibial response off of the EDB? How's that possible?
volume. I don't know. Volume conduction.
Yeah.
Yeah.
What is the only muscle in the foot that is not innervated by the tibial nerve?
We're the only muscle?
The only muscle in the foot that is not innervated by the tibial nerve.
Insert digitorum brevis.
EDB.
EDB is,
Yeah. So if you stimulate hard enough at the knee, okay, you're going to fire every muscle in the foot except for the EDB. Yeah. And guess what? This is what you're going to get. This is a big volume conducted response from those intrinsic foot muscles that are tibial innervated. So how do we fix this?
Lower your intensity.
Yeah. Drop your intensity down, stim again. Drop your intensity down, stim again. Yeah. And when you get to a certain threshold, this is going to change into a waveform that looks like this. Okay. Now, what's the other thing that you're going to see in terms of nerve conduction velocity when this happens? What's going to happen to that nerve conduction velocity from the popliteal region to the fib head. It's going to what?
It's going to slow.
No.
It's going to speed up because it doesn't have to
It's
go
going
past
to
the
be
tubular head.
blazing fast.
Mm-hmm.
Okay, because
So-
this latency difference is now going to be so short that you're going to have a nerve conduction velocity of 100 meters per second or faster. And actually, if we look at
okay.
this
Sorry,
carefully,
reversing that. Sorry.
you know, we've got a little bit of a positive deflection. If we move this to the first deflection, this could be 150 or 200 meter per second in
Mm-hmm.
speed.
Yeah.
And there is not, I can assure you, there's not a single nerve in the human body that conducts at 100 meters per second.
Yeah.
Okay, but we can just look at this and we know already, you know, that there's, that this isn't right.
Right.
Can I ask you a question here, Mark?
Yes, of course. That's why I'm here. I'm here for questions, guys.
That's what I love about you, man. That's what I love about you. So, on the onset of the ankle, okay,
Yes.
and I know that there's, it creeps up right there. Is, a lot of times, again, it's a big question whether you make somebody sick or not make somebody sick.
Uh-huh.
On the onset of the ankle, could it quite possibly be slightly to the right where it starts
Yes.
making that?
I think it's going to be right there.
Exactly
It's going to be another click, maybe two, to the right. And the reason we've got this is here and here we got nice flat baselines. Here we got that little curved baseline, and that's because we got the stimulus artifact. Okay, so this particular test, they were probably overstimulating to begin with.
Yeah.
And when you overstimulate and you're close to your recording electrode, this is what you're going to get. You're going to get that curved baseline, just like we see here in this, in this sensory. So it happens in motors also. Okay, so good, great question. For some reason, you guys just all.
Good job.
Yep.
Okay.
Okay, I'm back on.
Okay. Here we have, this is a tibial waveform. We're stimulating at the ankle, top one, and then we're stimulating in the popliteal area here on the second one.
Mm-hmm.
So analyze these and let me know what's going on.
Mm-hmm.
First question you ask yourself, do these waveforms look like tibial waveforms?
No.
Yes or no?
I don't know. Yeah, no.
Yeah. I mean, they look like a tibial waveform probably in somebody under the age of, say, 25, but before their feet have gotten beat to hell here.
Yeah.
Okay. Second question, are our cursors in the right position?
No.
I'm going to say no for one thing only.
Okay.
If we're going to be talking about the area underneath the wave, the one on the popliteal region is a little bit too low.
Which cursor?
The one that discerns the area, it doesn't have a letter. It's right. No, not that one.
This one right here.
Right there. Yeah.
Yeah. It should be up here. What's wrong with these cursors?
The onset, it should be back to where the positive deflection starts.
Onset should be at the first deflection from the baseline. Onset should be here, and onset should be here. Why do we have a positive deflection? What are 2 or 3 good reasons or things that can cause a positive deflection?
One would be not right on the nerve, right?
One would be not right on the motor point of the muscle, because
Okay.
we're recording off a muscle. So
Okay.
not being on the motor point of the muscle. What's another cause?
Switch polarity. You had the cathode where the anode was.
Uh,
Okay, never mind.
could be, probably not the best answer.
Okay.
Well, what's the other thing, the other situation where we tend to see a positive deflection? Volume conduction.
Yeah.
Okay. So again, we talked about the foot being a giant volume conductor for that tibial nerve. Okay.
Sure.
So our recording electrode is on the muscle belly of the abductor hallucis. And then we're shocking that tibial nerve. And we're always concerned with getting our amplitude as high as possible. Right?
Right.
Yeah.
Sure.
But if we see a positive deflection come in when we get our intensity to a certain level, what that tells us is that we're starting to volume conduct responses from other muscles in the general vicinity of our recording electrode. Okay, so we could be volume conducting from the flexor hallucis, from the quadratus plantae. So this is very, very common to see a positive deflection in tibial innervated muscles in the foot, and the reason is the whole foot is a volume conductor for the tibial nerve. So
What about
again, I'm sorry, go ahead.
What about dispersion on this?
Temporal dispersion. Bill, do you want to tell us about temporal dispersion?
So, thanks a lot. So temporal dispersion can occur, and what I'm looking at here is the distance between the onset and over on that little check mark down there. There are, as they become further apart.
What's that distance called?
That I wish I could remember that stuff.
Anybody?
But basically,
No.
That's
The
called
area?
duration.
Duration.
That is duration.
Okay.
You can see the time value here versus the time
It's
value
increased.
here. You can see it's increasing when you stimulate in the popliteal.
So that means that the axons are not all firing at the same time as the first time. They're all firing very, very well, but they're taking their time. They're firing sporadically on the second stem at the popliteal region.
Yes, and as that duration increases, that pulls down the amplitude. But what does it do to the area?
Well, hopefully the area stays the same.
The area stays the same. Exactly right.
So temporal dispersion, the area stays the same if things are good.
That's 100% correct. Absolutely correct. So we don't want to confuse this with conduction block. I have never seen in 23 years and 25 or 26,000 tests, I've never seen conduction block of the tibial nerve between the ankle and the popliteal region. I see it in the tarsal tunnel all the time, but I've never seen it over the long segment of the tibial nerve. And typically, because this segment in most men can be anywhere from 42 to 47 centimeters, over that long distance, the disparity between the fastest firing axons and the slowest firing axons becomes more apparent, which increases duration and pulls down that amplitude. So temporal dispersion in the tibial nerve is normal, completely normal. Just be careful that you do not call it a conduction block. What nerve is this?
The median.
This is a median nerve. This is this is absolutely textbook median. nerve here.
Beautiful.
Yeah. Yeah. Onsets are perfect. Peaks are perfect. How about this? This is also a median nerve, allegedly.
Rub.
Yeah.
Does this look like a median nerve?
Nope.
Negative.
What's it look
They
like?
got looks like they got a little ulnar nerve in it.
It looks like they got a lot of ulnar.
Yep.
In they got a lot of ulnar. Okay, again, we've got that positive deflection, which tells you that this is a volume conducted response. So what are a couple of mechanisms that could cause a median response, or I should say recording off of the abductor pollicis brevis, what could cause this to look like an ulnar issue? First case scenario, assume that the person is directly on the median nerve.
Right.
How do we get an ulnar response out of this?
I mean, you got too much amplitude.
Well, you got too much stimulation. You're stimulating way too damn high, and that stimulus is bleeding over to the ulnar nerve. Bill, you're a certified hand therapist, right?
Yes, sir.
Okay. At the wrist, at the distal wrist crease, where the median and ulnar nerves enter into the hand, how far apart are those two nerves?
About 1.5 centimeters maximum.
1 centimeter to 1.5 centimeters at the most.
Maximum.
So max. So you are, if you're overstimulating your median nerve and you're starting to stimulate the ulnar nerve, that's going to fire all of those ulnar innervated muscles in the hand. And lo and behold, you're going to get a volume conducted ulnar response. Because what big ulnar innervated muscle is in that first compartment also? In that first dorsal compartment.
FDI?
Oh,
FDI.
yeah.
Yeah. Okay, so assuming that the person is actually on the median nerve, and they get this at the wrist, they're volume conducting. At the elbow here, you've got to be really careful about your stimulus point at the elbow. I see all the times in trainings, new students doing the median motor test, and I look where they're shocking, and they're shocking the dang ulnar nerve.
Mm-hmm.
And it's like, hey, are you confident you're on the median nerve? And they look and they say, oh no. Okay. In the axilla, how far apart are the median and ulnar nerves?
They're just close. They're very close.
They're in the same neurovascular bundle.
Yeah.
From the mid-axillary region proximal, one's on top of the other.
Yeah.
So these nerves are close together, and we can get a lot of information in what our technique is doing by looking at our waveforms. If we're going from that to that,
we got a problem.
Yeah.
The other thing that could be happening, okay, instead of assuming that you're not on the median nerve, you let your stimulator slide 1 centimeter more medial, you're shocking the ulnar nerve.
Yep.
What if I was to tell you that this is the same person, same hand, and all I did was move my stimulator 1 centimeter more ulnar?
Oh, yeah.
Okay, you see that?
Mm-hmm.
Yeah, big difference.
So 1 centimeter, I go from having a perfect response to a not so perfect, response.
Right.
Now, assuming that you're not volume conducting, that you are on your median nerve for sure, you're not overstimulated, and you still get this. What's the third possibility of what could be going on here?
Martin Gruber action.
Martin Gruber anastomosis. Absolutely correct.
Yeah.
Absolutely.
You know, I wrestle with the Martin Gruber all of the time.
You wrestle with it from in terms of what sense, Bill?
Just trying to understand it. So I'm trying to realize, that many people have it, and yet, I still wrestle with, how to explain it, and I know this is probably not the scope of this right now.
Anything we want to talk about is the scope of this.
I'm just telling you right now, I wrestle with Martin Gruber's all the time.
The textbook says 18 to 20% of cadavers have median to ulnar communication in the forearm.
Yeah.
Ask me what I think the true number actually is.
What's the true number?
I think 30 to 40%. 30 to 40%.
Right.
So we've got these two waveforms. What's the third stem site that we would go to confirm that this is a Martin Gruber? Where would our next shock be?
The ulnar nerve at the wrist?
Absolutely correct. Ulnar nerve at the wrist. We would drop our stimulus intensity down to about 10%, down to about 10 milliamps, and we'd come way medial on that wrist. We'd shock the ulnar nerve, and we'll get a response.
Very similar to what we see.
Very similar to what you see, except probably smaller. Probably a little bit smaller response. Yeah.
Right.
So this person here did not have a Martin Gruber, but all I did, this might have been my wife's wrist here a few years ago, and and basically all I did, guys, is I moved my stimulator 1 centimeter more medial, and still got beautiful responses, but they're not median responses. These are ulnar responses. Okay, so this is an ulnar nerve, as we can tell by looking at the double hump here on the waveform. Here, looking at this, is this an acceptable waveform? Not worrying about these R's out here. I don't care about that. But would we accept this as acceptable waveforms?
Looks good to me.
Yeah.
Bill?
Yeah. Yes,
Yeah.
sir.
Yeah. Perfect.
Yeah.
I mean, we got next to no stem artifact. We've got nice flat baselines. Onsets are in the right spot. Peaks are in the right spot. Yeah. Take this 100% of the time. Oh, here we go. Median nerve.
Yeah.
Okay. Wrist stem, ulnar stem. What's happening here?
Definitely conduction overlay. I mean, you're putting too much juice in there, right?
Yeah. We're volume conducting here, but there's no positive deflection here. The waveform is changing shape. This is a completely different morphology, but there's no positive deflection like what we saw here.
Mm-hmm.
Okay, so it's possible that we may not be overstimulating.
Well, could we have not depolarized the wrist?
That is a possibility. And let's say, for the sake of this argument, we went back to the wrist, and this is the best we could get.
Mm-hmm.
And then we come up to the elbow, and we're absolutely on that median nerve at the elbow, and we get a waveform that changes shape and is about 30% larger here. Where's our next stem site? Where are you going to shock next?
Elbow.
Well, we've got the elbow here.
Oh, what about the
This is
axilla?
elbow. Okay, so we shock at the axilla, and it looks exactly the same as this one.
Mm.
Where do we shock next?
I mean, at the posterior. I mean, the ulnar elbow.
Ulnar at the wrist.
Okay, ulnar at the wrist. Okay.
Ulnar at the wrist. We want to shock ulnar at the wrist. If we shock ulnar at the elbow,
what's it going to look like? Is it going to look like the elbow?
Huh?
If we shock ulnar at the wrist, will that look like the elbow?
It'll look like the elbow, but it'll be smaller. It'll be a smaller response. And if you add the amplitude of that ulnar at the wrist with the median at the wrist, if you add those amplitudes, it's going to approximate what the amplitude of this is here. So what is this?
Oh,
What is this?
That would be Martin Gruber.
This is another Martin Gruber. This is another one.
okay.
Martin Gruber will wreak havoc with your nerve studies. You'll stumble upon one, and you'll spend 15 minutes trying to fix this. No matter how small you stem, or excuse me, how much you lower your intensity, this waveform's never going to change shape. It'll get smaller, but it's not going to change shape. And then when you maximize it, it'll be anywhere from 30 to 100% larger than this one here. So when you see this, and if you're confident that you were on the median nerve at the wrist and the median nerve at the elbow, drop your stimulus intensity down to about 10 milliamps, shock that ulnar nerve at the wrist, and if you get a response, bingo, you've got a Martin Gruber there.
Can you help me with the documentation on that?
Yeah.
How would you say that?
Yeah. So
let's say that happened.
Yeah. So let's just assume that everything in this study was normal. Okay. This was a normal study. There was no electrophysiologic evidence of focal nerve pathology, proximal nerve, plexus or nerve root pathology, polyneuropathy, or myopathy. Then my next sentence down, the way that I write it is, of interest, there is electrophysiologic evidence of median to ulnar communication in the right forearm, parentheses, Martin Gruber anastomosis.
Beautiful.
Okay, because Martin Gruber is a normal finding according to the literature in 18 to 20% of cadavers. But both Dr. McKibben and I would say that that number is probably more in the range of 30 to 40%. There's days in clinic where 50 or 60% of my upper extremity patients have had Martin Gruber. It's very common. And if you can't recognize it, it absolutely will wreak havoc with your nerve tests. Okay, so here, I threw this one in. Here we have a right suprascapular motor NCS recording off of the supraspinatus. And we're shocking at Erb's point here. So we're shocking the plexus up at the base of the neck. And this is our waveform here. Roy, I don't think you've done
Nope, I haven't.
You've not been taught this test, but Mark and Bill, both of you have done this at least in class.
Yes, sir.
What's wrong with this waveform? Why is this not going to be good data?
Well, first of all, it's at 5,000 microvolts.
Yeah, that's okay.
Yeah.
Is that okay?
Because our normative data for our motor tests are based on a gain of 5,000. What's
okay?
What is screwing this up?
There's nothing to be confident on anything in this. You don't know where exactly your onset is. It's hard to tell the speed. There's motor artifact afterwards. I mean, nothing really looks good to me.
Yeah, there's
really
a bit of a flat section here, but we got big stem artifact. We got this big sloping thing coming down here. We've got this highly convoluted waveform. Look at the duration of this thing.
Yeah.
Okay.
I wouldn't feel confident on that at all.
I mean, this is a giant turd here. Okay. Let me see if I can't.
I love that.
If I can't. See if red will show up. Yeah. Typically, when I see a suprascapular, it'll look something like that.
Yeah. That definitely is better.
So this thing here is.
What do you think the problem is here? Do you think
the problem is number one? I think. Well, first, they didn't choose the correct muscle to assess for a suprascapular nerve injury. Okay, what muscle lies directly over the supraspinatus?
Trapezius.
The upper trap. Yeah. So I think part of the issue here is they're not completely. Infraspinatus is where I would go first. Absolutely. Yeah. Because the amount of upper and middle trap over the infraspinatus is much, much, much less. Okay. And then the fact that there's this big stem artifact, most likely what happened is even at 300 to 500 milliseconds pulse width, they still weren't getting a decent response. And so they probably cranked it up to 750 or 800 and was just shocking the crap out of that herbs pool. And that's why you get this big stem artifact and you get this sloping baseline and this highly convoluted, temporally dispersed waveform. There's probably some upper trap CMAP in here. There's probably some supraspinatus. There could even be some infraspinatus there. You just don't have a clean waveform here. You have a waveform that's impossible to assess because of all of those reasons. Highly convoluted, stem artifact, temporally dispersed. There's just nothing good with this. I mean, this is a technically difficult test to do. Sort of, but the supraspinatus is not the one that you want to check. You want to go to that infraspinatus first. Okay, so here we have a median nerve. So we've shocked at the wrist, then we've shocked at the elbow, and I've still got the pen turned on here, so I want to.
It looks pretty good, but it looks like it might have been understimulated at the elbow.
Yeah.
Understimulated elbow or overstimulated at the wrist.
At the wrist, yeah.
Why is it possible that this could be overstimulation at the wrist? What in our waveform is sort of leading us towards that?
Positive deflection.
Right there.
Just a little bit.
Yeah. Just that little bit of positive deflection.
Yeah.
So to fix this, basically you decrease your intensity, stem again, decrease your intensity, stem again. At some point, as you decrease, that's going to go away, and it's going to look, amplitude's going to drop a little bit, and it's going to look just like this one. Here at the wrist, if we kept stimulating, and I bet you, in this case, this wasn't me, but I bet you if we kept stimulating, this amplitude would keep getting larger. The amplitude would keep getting larger. Yeah. It would start to sort of maybe change shape to that little sort of double hump configuration. And this positive deflection would get deeper, which indicates that you're volume conducting that ulnar nerve.
Mark, that makes total sense, man.
Yeah, I think you explained that well, because, you know, when you see that, when you draw it out like that, like with the big positive deflection, the double hump, that's an obvious, you know, like overstimulation, volume conduction. But I think it takes a little bit more of a thought or an eye to see that's starting to become wrong. It hasn't gotten, well, it is wrong, but it's not as obvious yet. But you have to see the detail and noticing that, know that you've got it wrong.
Yes, this is much, much more subtle than that previous one. And a lot of times people will miss this, okay? So, and they'll call this a conduction block when it's not a conduction block.
Right.
If I was thinking that this was a Martin Gruber, I should see that positive deflection here also. Question?
So sometimes, can you hear me, Mark?
I can.
So sometimes the art is not to make disease, but to make things look normal, you know? To not necessarily create disease, but to try to make things look the same, right?
Absolutely. 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 If you're recording off of a muscle and you're stimulating the same nerve distally to proximally, that the morphology of that waveform should never change. It should stay the same. And if it changes, that's either technical or it could be anatomic due to some sort of weird, anastomosis or something like that. But usually, with the exception of the median nerve, and you see a change in that morphology, that's usually technical. Guys, I think every one of you will agree here. With needle EMG, if you know where the muscle is, and if you can get the needle into the muscle, EMG is easy, right?
Yeah.
It's easy.
Yep.
What I believe, and I think you'll agree, that doing good quality, accurate nerve conduction studies are way more difficult than doing the
true art.
Agreed.
It is an art.
Yeah.
It absolutely is an art.
Mm-hmm.
And it's frightening that some of our competitors out there utilize technicians whose training, especially if they're not certified and have gone through a formal training process, those are the people performing the more difficult part of the test.
Oh, yeah.
And what's the guarantee that they're producing good data? To me, I just need to look at the waveforms, and then I look at the tables. And when I see 100, I saw one last week, 143 meter per second sural sensory. 143 meter per second sural sensory.
Oh my gosh.
Okay. There's no sensory nerve in the foot that records or that conducts at 100. I mean, there's no nerve in the human body that conducts at 100 meters per second.
Oh, yeah. There's no doubt.
What's this?
No go.
Okay.
That's a beautiful, technically perfect tibial H reflex with one problem.
it's a no-go because of the line. It's not supposed to be. It's supposed to
Yeah.
be.
First deflection from the baseline, somewhere about right there.
Mhm.
And I saw this and I went, man, this is beautiful.
Gorgeous. It's beautiful.
Perfect. Except,
Yeah.
look where they put the cursor.
And
Okay.
can we
And
Sounds
they
like
called it, the machine called it abnormal because with the cursor right here, the latency was 0.4 milliseconds prolonged.
Yeah.
So this report came
Beautiful.
back as bilateral S1 radiculopathies with beautiful. I have never seen an S1 radiculopathy, a true S1 radic with a reflex that looks. I mean that's perfect. That's technically perfect, except for this in,
Yeah.
the,
Right.
in the wrong.
Now, would you move the other line over to kind of?
Yeah, this is your split screen here.
Yeah.
I think what happened is they had it about right here, and it was just screwing all this up. So in order, again, would I move it over? You could move it over if you want to see a little bit smaller M. Keep in mind that with it over here, that the gain is at 1,000, and on the other side, it's at 2,000. So if I move that from here to here, that would only look half as big as as it is. So it's fine with it there because I don't care about the M. If I have an H that is this beautiful and this perfect, I don't give a crap about that M.
Dr. Brooks, on that right there, if the you spit it out right there in the report calling bilateral S1 radic, it'd just be a real shame if that person ended up having surgery or something like that.
Guys, that's why what we do is so damn important, and that's why it's so important that we're technically good, excellent at what we do.
Can I give you a case study on that real quick?
Absolutely.
So, a local neurologist, a car accident, female, did a EMG nerve conduction study on a patient who had, and he called it TOS, thoracic outlet syndrome.
Ooh, okay.
Never stimmed above the elbow.
Okay.
He didn't stick above the neck. He didn't do an evaluation. It's just 2 weeks ago for me, and I really, really, really drilled down hard on it. And the problem was is she had bilateral, very, very, very mild carpal tunnel syndrome and very, very mild cubital tunnel syndrome. He didn't inch. He didn't do a lot. I'm not coming down on the guy. I'm just saying he went there real quickly. He did just a little bit of, did a very easy nerve conduction test. Did not go above the elbow, which is weird.
So what?
All he did was
made him
the
call it a thoracic outlet? What in his nerve test made him call this thoracic outlet?
I had the ulnar nerve, but he did not do the medial antebrachial either.
Okay.
And so the attorney who I knew, and I'm not saying that I'm perfect or anything. I'm just saying that it's important that we drill down.
Sure.
And I'd rather drill down further. But what Rick and I just because I sent Rick's my guy and my mentor, and he basically said, yeah, I mean, you basically kept this person from having a thoracic a first rib resection.
Yeah. What?
So it's not all fun and games.
No, it's not. He was basically calling this a lower brachial plexopathy
Right.
based on some ulnar nerve findings. What's the single most sensitive nerve test for detecting lower, i.e., lower trunk medial cord brachial plexopathy?
I mean, the medial antebrachial cutaneous.
Nope.
Mhm.
Ulnar sensory to D5.
Right.
Okay. Ulnar sensory to D5 and the duck,
Duck.
the dorsal ulnar cutaneous, are
Yeah,
abnormal in 96% of
and her duck
lower
is
brachial
normal.
plexopathy. Medial antebrachial cutaneous is only abnormal in 68%. So he was looking, okay, it sounds like he was calling a lower brachial plexopathy based on maybe an ulnar sensory abnormality.
And I didn't bring that up to make anybody look better or worse.
Yeah.
What I meant to say is that we need to, humble ourselves and realize that we're keeping people from either having surgery or promoting, a surgical intervention. We need to be very, very, very sober about what we do.
Absolutely. We can't put out giant turds here. Okay, because not only are we going to run into a situation,
the word of the day.
It's the word of the evening.
Yeah,
And
I agree.
It's
Third.
in the military. It was an acronym for something, and I can't remember exactly what it was off the top of my head. But not only can we prevent people from getting unnecessary surgery or get the person that needs surgery done, okay, but we're under such scrutiny that if we put out the type of reports that many of our fellow colleagues do, we would be brought up before the medical board, for malpractice. I saw a case Monday. Was it Monday or was it yesterday? It was Monday or yesterday. 73-year-old guy, okay, numbness and tingling in his hands and neck pain. And he was absolutely convinced that he had a pinched nerve in his neck. And so, he's sitting on my table and, he goes, I've done my, clinical exam. And, he goes, so, Doc, what do you think's going on? I said, well, I think we're going to find out that you have some significant carpal tunnel, and you may or may not have a little neck, nerve root in your neck problem, and he goes, I think you're both wrong. He goes, the other doctor that sent me here said the same thing, that I got carpal tunnel, but yeah, I think you're wrong. I think we're going to find that I got a pinched nerve in your neck. I said, well, let's find out. Okay. This guy, in his right hand, he had 1 out of 5 strength in his APB, in his thumb abduction. He was 1 out of 5. But where he was older, his hands were just that ever so slightly puffed up. You couldn't see the atrophy of his thenar region. And when I pushed down on his skin, dude had a big hole right there. Okay, so I did his median sensory test, nothing. Did his ulnar was fine, radial was fine. Did his median motor, okay. At the wrist, I got no response. At the elbow, I got no response. Shocked his ulnar nerve at the wrist, got no response. Okay, so I went into his palm, shocked his median nerve in the palm, and got like a 0.3 millivolt response. Got a little something there. Okay, so did the rest of his test, had a little bit of slowing across the elbow, but that wasn't his problem. So when I stuck his APB, what do you think needle EMG showed in his APB? How about insertional activity? Was his, insertional activity Increased, decreased, or normal?
It should have been increased.
Well, his was decreased. I'm poking around in there, and
How long has he had the problem?
He's had the problem for years, but he said it's gotten worse since April of this year. So I'm tapping the tip of that needle off his bone, and I'm getting like little 10 millisecond little bursts. But when I leave the needle alone, the whole screen, I thought I didn't have a stable baseline, but when I change my gain, just continuous small amplitude, positive sharp waves, just continuous. Okay. So when I had him contract the muscle, what do you think I saw?
Trying to think.
Polyphasics.
Didn't see any polyphasics.
Yeah.
How many motor units do you think he was able to recruit?
I would say less. I would say a very decreased motor unit.
He had one motor unit that he could fire. And I checked.
Was it ginormous?
Huh? No, it
ginormous?
wasn't, which was surprising. I was thinking that it would be a large amplitude, but it wasn't. Okay? But it was firing at about 40 to 45 hertz. It was fast firing.
Wow.
Why would he not have large amplitude motor units in a carpal tunnel this severe? Because normally that's what we would expect to see is some large amplitude fast firing motor units.
Sure.
Why did he just have one little itty bitty one firing?
Well,
Maybe no.
Because he had no useful muscle fibers yet left there. And there was just no muscle left to fire. This was so extremely severe that not only had he lost pretty much all of his axons, okay, his muscle fibers are gone also. And and his neck was clean. I mean, his EMG of his arm was clean except for that APB there.
Yeah.
And again, it's and of course when I tell him, he goes, well, can I get it fixed and get the use of my hand back? And so so what do you think the prognosis is for this guy?
Not very good.
Very poor.
Yeah.
But I'm not going to tell him that. Okay. I'm going to say, hey, get back in and see your hand surgeon. And this is my way of just cowarding out of this. But you know how some doctors are. They don't want you discussing.
They don't want you to tell them the truth.
Yeah. Yeah.
You're just a dumb physical
and this guy here, his hand surgeon, him and I are get along great. He's going to tell him the same thing. He's going, there's not a thing I can do for you. I can treat your neck and I can get your neck feeling better. But, in terms of, restoring function to your hand, not a lot that I can do here.
Is that pretty much the way to handle that? Because, when I was doing some EMGs, they'd ask me kind of my thoughts. First of all, I wasn't sure I always knew enough what to say anyways. But if I did know or had a good idea, is that a good way to phrase it? I guess I could work on your neck.
Depends on your referral source.
Okay.
It depends on that type of relationship. I've got one or two that don't even want me to discuss the results of the test with them.
Okay.
And I just tell the patient, I said, look, Dr. So-and-so wants to be able to discuss these results with you. I'll get everything reviewed this evening and, to him, he'll have the test tomorrow. And I said, let's get you scheduled to come back in and talk to him, but, in some of the cases that, get, referred to us and we see in our clinics, that's been referred maybe by, one of our hand therapists or something like that. I'll typically,
what's interesting around if you have PAs or nurse practitioners sending you patients. I have a ton of PAs and nurse practitioners sending me patients.
I do too.
And they want me to talk to the patient.
Mm-hmm.
And tell the patient what's going on, explain to the patient what's going on.
Isn't that funny,
Mm-hmm.
Bill, that, that the PAs and nurse practitioners that are more on your level of training want you to do that, okay, as opposed to some of the more, and I'll use the term pompous surgeons that don't want you to do that. Isn't that, isn't that interesting?
Oh, yeah.
Okay, so let's get through here because we are having so much fun.
Oh, yeah.
That we're almost out of time. This is a median nerve H reflex recorded off the flexor carpi radialis. Now, let me just say this about this test. Okay, this is probably one of the most difficult nerve conduction tests that you can do. Okay, I did my doctoral dissertation on H reflexes, and I'll be one of the first people to tell you that unless you got fantastic skills, don't even think about doing this test.
Yeah.
Because you'll spend 20 minutes trying to get it and you've wasted all that time. What we have here is we have an M response. This is an M response.
Right.
And the system put the cursor between the two heads of this M response. The H is gonna pop out here somewhere.
Right.
Okay. This is
it actually looks like an M, like a cursive M.
It sort of does look like. I mean, it's telling you right there that hey, this is an M response here. Okay. So this is a no response. I've looked at 2 reports from some of my HODS folks. A couple of times they've tried this. They've got nothing. You know. And so until you have done a lot of these, don't do it. But I will say, here a couple of 3 weeks ago, guys, when I sent out that case of the day, where I sent out that H reflex, this test, when you can get it, is when people have cervical myelopathies. If they have a big spinal cord lesion at C5 or C6, you'll get this test. You'll get very large amplitude H's because of the spasticity. Other than that, this test is very questionable. This is another. Yeah, this is another. Median. Okay. Again, we have an M response here. We've got the trough here. The H will pop up somewhere over here. Machine put the cursor right in the base of the trough, and this is supposed to be a response. There is no response here. There is nothing here except for an response. This is a tibial H reflex. Take a look at this. Is this acceptable?
Yes.
Okay, Bill says yes. Mark, Roy?
I'm looking. I'm gonna go yes.
Okay. Roy?
Yeah.
I'm gonna say from what I've seen, but I'm not really doing them. So
yeah. I mean, this is fine. Okay. You can see how the deflections line up perfectly here. The waveforms look the same. It's just not been rastered. Or it is rastered. It's not been overlaid. So
Right.
I mean, this is fine. Same patient, but on the other leg. Okay. How about this?
I'm going to say yes on that too.
Yeah, I am too.
Okay. So I'm going to say no.
I'm going to say no too. I was waiting.
Okay,
Sorry,
Mark, tell us why you're saying
Howard.
I know, I waited, didn't I? I know, I'm shameful of me.
Notice here how the waveforms line up. perfectly.
Right,
They all
right.
look the same.
Not just do
H's,
they not. Yeah.
H's should look the same. They should overlap perfectly.
Mhm.
Okay.
And
What
not
are
just that.
these?
Yeah, they're all everywhere, and some of them start in one spot and some start in the other.
Yeah. What are those responses that
That's
have
a
variations in
the
latency, amplitude, and morphology? What do we call those?
F F F
F,
waves.
A
F
wave.
waves.
These
I
are
got it.
F waves.
All
Yeah.
right.
Yeah.
These are F waves. They look different. These two here sort of look the same, and that's probably why the machine
Yeah, that's
put the
only
cursor.
the reason why I was looking at it. Those two wavelengths alone, and then the next one above them, and the next one above that. That's the only
Yeah.
reason why I was looking at that.
Yeah. But if you overlay all these, they're not going to overlay. They're all going to look different.
So what do
Yeah.
you do in a case like this?
Well, look up here. Look at the first stem.
Mm-hmm.
They maximized the M on the first stem.
Yeah.
If we go back, H reflexes are generated with submaximal stimulation. So
Right.
here we basically have no M, but we're starting to get the H. The second one, we have a little bit larger M, but a larger H. Okay. If we look at this one, they started right out maximizing the M. So what happened, I think, is when they went from this side to the other, they didn't drop their
Lower
intensity
the
back
stem.
down. And so they maximized the M. Most likely, this patient probably had an H, but it's come and gone because as the M gets bigger and bigger, the H will eventually go away and it'll be replaced by F responses.
Right.
Okay. So that's what's happening here.
Okay.
Too much intensity with this first stem, and we're generating F waves instead of H responses. Very, very common technical error that I see happening. So again, we've got to be able to catch this at the time we do the test, drop our stimulus intensity back down to 5 to 8, start there, and you'll end up getting something that looks like that.
There's a technique that you showed me, Mark, a long time ago to help get the H reflex motivated a little bit.
Yes, that's also an F technique. And when I say F, I mean F for facilitation. Okay? And what you can do is when they're prone, you can have them gently plantar flex their ankle and foot against your hand, which is firing the gastroc, and that will prime the anterior horn cells and make them more susceptible to generating a good H response.
You do that during stimulation?
At the same time?
Yes. I mean, what I'll do is I'll put 1 or 2 fingers on the ball of their foot and I'll say gently contract. And right when I see the muscle start to contract, that's when I'll start my stimulus. Stim, increase a hair, stim again, increase a hair. And oftentimes you'll get beautiful H's. And it'll work. It works on both sides. You can say you're doing H reflexes on the left side, you can have them plantar flex on the right, and it still activates the alpha motor neuron pool in the spinal cord, and you'll get beautiful H's on the contralateral side also. Very cool. Okay. I want to discard my drawings here. Yeah. So our time, we've actually gone over our allotted. That went sort of quick. Yeah. Any questions about anything that I can answer while I got everybody on the line? If not, as always, shoot me an email or a text or whatever. Rick and I are here to help you. So.
Well, Mark, actually, I do before we're done here.
Yeah.
You did fantastic, Mark.
Yep.
Yeah,
we
that was
do.
great. Thank you, Dr. Brooks.
Yep.
Appreciate
Guys, I'm glad you had fun. And what's important about these webinars is that we're able to participate and
Right.
interact and ask questions, because that's how we learn. We don't learn with me blabbing on for an hour talking about a bunch of crap.
Right.
It's when we can interact and ask questions.
Hey, Dr.
You know-
Brooks, Dr.
Yes.
Brooks,
Yes.
it's not crap tonight. It's a big turd. Yeah.
Yes.
It's all about
Yes.
big turds. It's all about
Yes.
big turds.
Yeah.
Big old turd. So, hey, they're, Oklahoma there. So, what about your Kyler guy stealing the
Oh my
Heisman?
God.
Oh, stealing. Come on now. Come
So
on. He had a great
overrated.
season.
So
Yeah, look at the stats.
overrated.
Oh, baloney.
Oh my
Do you
God.
know,
Overrated.
Mark, that's probably the worst thing that could have happened to Oklahoma is for
Well,
him to win the
Worst thing could
Heisman.
happen to him.
Do you know that Alabama's going to try to hang 100 points on Oklahoma?
Oh yeah.
Well, our
Alabama
defense is not very
Back
good. I'll admit
OU
that.
like redhead's stepchild.
Oh, come on. I've got a bet on it with one of my coworkers. We got a little lunch bet going on. He's at
Hey,
Alabama.
by the way,
fan.
UT is 50-50 with OU this year. They just got smacked around the last time.
Yeah.
Yeah.
Well,
Okay, guys.
we'll see.
Be good.
We'll see.
Okay. Take
Have a
care,
good
guys.
night. All right,
Bye-bye.
Right.